Good morning. Thank you all for participating in today's teleconference. I know the potential for an Ebola outbreak in Alabama is of great concern to many people. The Alabama Department of Public Health is taking several steps to ensure that if Ebola is confirmed in Alabama, we're able to respond quickly and effectively. The Department of Public Health and the Alabama Hospital Association have partnered together to ensure that every healthcare official in Alabama knows the proper steps to identify potential cases of Ebola. As a doctor who has spent time in an emergency room, I know how critical a proper diagnosis is. The better history that is taken when the patient is in the ER, the better chance we have in finding a proper medical diagnosis. That's what this training is all about. We want to make sure that you know how to diagnose the symptoms of Ebola and how to protect yourselves and the patient. My friend, Assistant State Health Officer Dr. Albert White, will be speaking to you shortly. I hope you all learn a lot from today's teleconference, and thank you again for taking part and helping our state be better prepared.
Thank you, Governor Bentley, and welcome everyone to the Alabama Public Health Training Network. The 2014 Ebola epidemic is the largest in history, affecting multiple countries in West Africa, and now we are seeing just a few isolated cases here in the United States. As everyone knows, these few cases originated with people who visited these countries and came to the U.S. asymptomatic and then became ill. Healthcare facilities and practitioners at all levels around the United States are working to institutionalize the latest infection control practices, and today we will discuss Alabama's efforts to prepare. We will also discuss and demonstrate the use of personal protective equipment known as PPE. Thank you for joining us today for our program, Nurses Matter, Ebola 101 and Personal Protective Equipment. Our objectives today are to discuss Alabama's efforts to prepare for Ebola, to identify the characteristics of Ebola, including transmission, symptoms, diagnosis, and treatment, to discuss Alabama's public health planning process and available resources, and to describe the critical role of nurses in providing care to those with suspected or diagnosed Ebola, and to describe personal protective equipment required for caring for Ebola patients. If you have a question about anything being discussed, please call or email during this broadcast. The phone number and email are on the screen now, and they will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need this to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. ADPH is also an approved provider of continuing social work education by the Alabama Board of Social Work Examiners. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, Continuing Ed credit will only be awarded for 1 year and will expire on November 30th, 2015. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. Please note, the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of their respective jurisdiction or agency. I'm Dr. Tom Miller, Chief Medical Officer for ADPH, and with me today is Dr. Albert White, Infectious Disease Physician and Public Health Area 3 Health Officer. as well as Patty Miller, Infection Prevention Coordinator at Baptist Medical Center South here in Montgomery, Cynthia Murphy, Director of Clinical Education, Sherry Harrell, Infection Prevention Practitioner, and Denise Hinton, Clinical Educator from Baptist Medical Center South. These last three will be joining us later in the program. I would also like to acknowledge the co-sponsorship of this program from the Alabama Department of Public Health, along with our partners, the Alabama Board of Nursing and the Alabama Hospital Association. So thank you all for taking time out of your busy schedules to be here today, and let's go ahead and get started.
Thank you, Dr. Miller. Good morning to everyone. It's a pleasure to be here and be able to participate in this program today directed towards nurses around the states and other healthcare workers. As we know, the Ebola outbreak has been with us now for several months. It was originally noticed in West Africa back in December of 2013. And it has been getting really serious there, and everyone is concerned about it. This virus was first described or discovered in 1976 near the Ebola River in the Democratic Republic of Congo. It was then known as Zaire. And since then, there have been several outbreaks in the region in Central Africa, but it had been fairly well contained. The current outbreak is now in West Africa, as you see on this slide. The countries that are involved mainly now are Sierra Leone, Liberia, and Guinea. In the Central African area where the previous outbreaks in the Congo, in Uganda, some parts of Sudan had been ongoing in the past several years. But there has been none that has been as deadly and as widespread as the one that is currently ongoing in the region. There are several subspecies of the Ebola virus that has been known to cause disease. There are 5 of them. The Zaire Ebola virus is the one that is currently responsible for majority of the outbreak that is ongoing in West Africa. The Western virus is one that had been noticed in the United States several years ago, but is not known to infect humans. The Sudan virus, the Thai forest, and the Bundibungo is another virus that has been responsible for this infection. We talk about how the virus is transmitted. We know the ecology of it, that we have found that it can be in some animals. The fruit bat has been one. There's some primates that have been known to have the viruses, and other animals in Africa. And it's pretty important because there seem to be, at some point in time, the virus may have come from some of these animals and have infected humans, and then the transmission is subsequently is from humans to humans, and that is the major source of the virus transmission today. I'd like to take some time now to review the geography of where this virus comes from and where people who have the Ebola virus disease would more likely come from. And it is these 3 countries in West Africa: Sierra Leone, Liberia, and Guinea. I had the opportunity to talk to some emergency medical personnel and fire service, ambulance crew in Tuscaloosa recently, and I've given some talks in other places, and based on my experience from calls that I've gotten from around the state, I thought it was very important to stress the geography of where this disease is coming from. People get it mixed up, and causing a lot of confusion and unnecessary delay in the care of patients because they just don't have it right. Africa is a big continent. It has 57 countries, and this is a map of Africa that I share here with you. And again, only those 3 countries in West Africa are the ones that are currently involved in the outbreak. There were a couple of other countries, Nigeria and Senegal, that had reported cases of Ebola in the recent past. There was Patrick Sawyer, who traveled from Liberia to Lagos, Nigeria in late July, early August, and was sick. He infected several others in Nigeria, a total of probably 20 cases overall, with almost half of them dying. And there were about 900 people who were exposed to Mr. Sawyer in Nigeria. But since then, it's been more than 2 incubation periods now, and Nigeria has been taken off the list of a country that has the potential to have someone infected with Ebola. Senegal also had one patient that was found there, and they had about 67 or so contacts to that particular patient, and all of those contacts have passed the 2 incubation periods, again 46 days, and have not come down with Ebola. So Nigeria and Senegal is not on that list. It so happens that Nigeria is is the most populous nation in Africa, and there are lots of Nigerians that travel. And sometimes we confuse Nigeria and Liberia. So when someone says they come from Africa and they said Nigeria, and people start to, try to activate the system and all of that, let's be clear about this, that Nigeria is not one of those countries. And I'm spending some time to talk about this because as nurses, as healthcare workers, people will be looking up to us and asking us questions if they're not certain about whether this person should be someone of interest or so. And they will ask you, this person is from Nigeria, you should know this, and to be able to no, this is not someone of interest. Rather than carrying it along, and then I get a call in the middle of the night, or Dr. McIntyre gets a call in Montgomery to ask about somebody who come from Nigeria. The other important historical event is that that person should have come within the last 1 month. 21 days, we say. I'd make it easy. I say 1 month. Okay, so someone who came from Africa 2 years ago doesn't meet the criteria. And I say that because that happened to be one of the sort of the end result of a patient that we had to investigate, that someone had come from Nigeria 2 years ago. So that person could not have been infected. And again, for someone to just say, the person is from Africa, and everybody gets all concerned, that again, there's stigmatism about this with Africans around the country now, and especially with those from Liberia, Sierra Leone, and Ghana. Africans and people in West Africa have a lot to deal with and to have to be bothered with this unnecessary stigmatization. So please, as healthcare workers, let's get this geography straight and recognize that it's only those 3 countries within the past month that we will be concerned about. Okay. How many cases of Ebola has been found so far? I mean, this thing has been updated almost every 2 or 3 days. And again, the countries involved are Guinea, Liberia, Sierra Leone. The total Ebola cases so far, I think that goes to like October 31st, have been 13,540 in those 3 countries, with Liberia having the most numerous amount of cases. And out of those 13,000, we see that just about 5,000 have died. That's less than 50%. Early on in the outbreak, I think when the New England Journal reported the first 9 months, they were showing mortality rates of up to 70%, but those are in certain areas. But the overall, I see, is less than 50% right now. The other countries on this list have been Senegal and Nigeria that I talked about, and now there's one case that had been found in Mali, a young 2.5-year-old whose grandmother came from Guinea after attending a ceremony there, and the child got sick and died, and the Malians are now making contact with all the people who may have been on those buses or lorries that they travel on to make sure that they don't get infected, and we have not heard about another case. There have been other cases that been identified in Spain, and of course in the United States, we know that there have been 4 cases here so far. So again, majority of the cases are coming from West Africa, from those 3 countries. And again, not everybody from those 3 countries will be infected. I mean, those are big countries too. Guinea has a population of 11.8 million. Sierra Leone has a population of 6.1 million, and Liberia has a population of 4.1 million. And out of all those people, we find out that right now, 13,000, even if that number is underestimated, is still is not majority of people from these areas being infected. As As we know about the cases in the United States, we know there have been 4 cases reported here. Mr. Eric Duncan, who came from Liberia back in September and went to the hospital in Texas, and we know what all transpired there. Subsequently, we had 2 nurses that participated in caring for Mr. Duncan who became infected. And that's one of the reasons why we're doing all of this now, because we all have learned, or we are learning from the experience that they had in Texas in dealing with Mr. Duncan and the subsequent infection of 2 nurses there. That's why some of the things we're going to discuss here today, the PPEs, the recommendations have changed over time to make it more protective for the healthcare workers, because we know that healthcare workers are those who are at increased risk of becoming infected, especially when they are caring for sick people. We also know about this 4th case in the United States about a physician who had worked in Guinea and returned, and he was doing self-monitoring and subsequently reported fever and was subsequently diagnosed with Ebola on October 24th. He's currently in a hospital in New York. He's been isolated. All his contacts have been identified, and they are being monitored now, and we have not had any subsequent case associated with his infection. The transmission of Ebola virus, we know that it is transmitted by people who are infected and have become sick. It is highly present in the blood and body fluids of these individuals, in the excreta, the vomiters, the urine, or those places, again, of symptomatic patients. So patients who have not become symptomatic but have been in the area, have taken care of somebody, they are not able to transmit the infection. The infection usually occurs, again, from human to human by direct contact through broken skin or unprotected mucous membranes. With Ebola virus disease, an infected patient's blood or body fluid is highly infected. We do not know that Ebola virus is transmitted by airborne route. I know this has been a lot of talk around the country, and people, talking about it, they're talking, about, that it might mutate to do this. It has not happened yet, and the ways in which it is transmitted is what we know today. We also know that if you have instruments or sharps and things that have been used in caring for a patient with Ebola, and it has their blood or something on it, those could be areas in which you could become infected. Direct contact with coughs of a person who has died of Ebola. This has been a very important method of transmission in West Africa. It is unfortunate that some of the practices there for burying individuals have been, continued so until now. I think the government in these countries have stepped in to try to make it very difficult for family members to tend to their dead, to their loved ones, to bathe them and do all of that. And people are believing now that, yes, this is a method in which they can get infected if they have contact with the coughs that can be highly infectious. Indirect contact with an Ebola patient, infected patient's blood or bodily fluids by contaminated objects, soil leaning, soil or used utensils, those are other methods in which the virus could be transmitted. Ebola can also be transmitted by contact with blood, body fluids of meat of an infected animal. And, I had the opportunity to talk to a group of Liberians in the state recently. Dr. Mark Wilson and I from Jefferson County had this opportunity, and that was one of the questions they were concerned about. A lot of people in West Africa use or have bush meat, as they call it, as a primary source of protein. And they've been eating bush meat all along, and they say, well, we've never gotten infected. What are you all talking about now? But because we know that when the virus is in the region, some of these animals, like the primates and like some what they call deer meat in Africa, those can be infected. And it's at the time of butchering the animals, when they have hunted it and killing it and cutting it up and carving it, and their blood can come in contact with them. That is when the virus is transmitted. But many of Africans, they cook their food very well, and if they are not involved in that part of preparing those animals, the risk of them getting it from cooked food is less likely. And I had to explain that to this group of Liberians that we met with. Human-to-human transmission is, again, this is primary. Infected persons are not contagious until they are symptomatic. And this is something we need to be very confident and comfortable about, because otherwise, again, it will make people who travel to the area and come back here, people don't want them to come to school. They don't want their children, their second cousins to come to school, and all of that just because they've been in the area. And if they're not sick, they cannot transmit it. I know we have tightened up the restrictions about these people and how they are to be monitored, which we will talk about later on. But again, someone cannot transmit the disease if they are not symptomatic. And the infectiousness of body fluid increases when the patient becomes more ill. So as someone becomes more ill and they're vomiting, they're having diarrhea, those body fluids are highly infectious and they can infect someone. Human-to-human transmission of Ebola virus by inhalation aerosol has not been demonstrated. Again, that's going to airborne transmission. This is a chart that shows the different body fluids and it shows that the blood, again the urine, the saliva, and all of these things can become infected, and you can find virus in the early stages of the infection. And as the patient gets better, there's less and less in there. But we also find out that there can be several days after the acute phase of infection that some of their body fluids, including the semen, can still be contain the virus and could be a potential source of infection. Ebola virus disease risk assessment. And this is something that, again, has been going through changes from the CDC. As we know more about it, now we have these 4 risk categories: high risk, some risk, low risk, or no risk. Again, this is someone who has been to the area and has become symptomatic. Those patients who are at high risk, you may have your slides there, you can go through it again. These are people who have had direct contact with blood and body fluids from a person who has been sick. These would be probably healthcare workers, volunteers who have gone to the region and worked and took care of people in the treatment units, or family members of household members of people who have been sick and they've been around them, or someone who has been preparing a body for burial, or all these kinds of things in the region. These are people who will be at high risk. Those who have had some risk will be close contacts of a person who have developed Ebola virus disease but were not sick at the time that they were in contact with those patients, which makes it less likely that they may have been infected. Close contacts mean being within 3 feet of a person sick with Ebola for a while. Now, I know we have heard about these patients that have traveled from one place to another, and many of the people who, well, all of the people who were on the planes that traveled with these people, I would have said, well, yeah, they had some risk. And we've seen so far that the monitoring of people who are on the plane with Patrick Sawyer is over now. Nobody on those plane flights that Patrick Sawyer was on, who went to Nigeria, has gotten ill. No one on the plane that Eric Duncan traveled on to come to the United States has gotten ill. The nurse in Texas who traveled to Ohio from Texas when she was supposed to have been a little bit infectious, had a low-grade fever. So again, all those people on Frontier Airlines, no one has gotten sick yet from it. So I mean, it's although this organism is infectious, but it's not a very contagious virus like you would get how influenza or smallpox or tuberculosis or something is spread. So you have to really have some close contact with sick people who are rarely symptomatic. Low risk but not zero risk, again, would be maybe someone who has spent time in the country, have been there for some other reason, has been in the room with someone who may have had Ebola, or someone who may have had contact with some of the Ebola. but they hadn't gotten sick yet. And I think majority of the travelers, the people who come from that region, would fall in this group, low but not zero risk. And then, of course, there will be others who have had no identifiable risk at all. They have had no contact with any sick person. They have not visited anybody in the hospital. They were probably in the country mining gold or something like that, and that's, they really did not have any risk factor at all. Or there was someone who had not been to the country for, although they, come from Liberia a year ago, that person has no risk, okay? And I want to emphasize the geography and the timing is very critical and important. Early clinical presentation. When someone, again, now you've been exposed, you got into your mucous membranes, it got into your broken skin, and you most likely are going to come down with the virus. Depending on how significant your exposure was will determine how quickly you get sick. And if you get sick within a few days, the first or second day after exposure, that's bad news. That means you really got a good dose. But the longer it takes for you to get sick, the less likely that you're going to have a lot of symptoms, the more chances for you recovering. And again, we see some of the people here, the cases in the United States, several of those nurses have recovered already, and they probably did not get a real high dose, but again, they were in close contact with someone who was really sick at the time. The signs and symptoms include fever, chills, myalgias, anorexia, and some people get GI symptoms, nausea, vomiting, watery diarrhea, abdominal pain, and others, headache, conjunctivitis, hiccup, rash, chest pains, shortness of breath, and then when you start to get hemorrhagic symptoms where you're vomiting blood or having blood in your stool, that's pretty scary, and it can be really discomforting. I heard someone talk about working in the region and saying some of the bad signs that we see is other than bleeding is when this person starts to get a hiccup or so. They say, oh boy, that's a bad sign that they could really be getting sick. But those clinical presentations, again, depending on how much exposure you have, they could happen early or they could happen late in the disease. If it happens really early, your chances of getting really sick is high. Other possible infectious causes for symptoms, and this again has been one of the things that we need to be concerned about in patients who have returned from this area and meet the criteria for the time period and all, and presenting for evaluation. We have had the opportunity to evaluate 2 or 3 patients who met the criteria, had gone to the region, but after careful history taking and finding out that these individuals had not been on anti-malaria prophylaxis, we were able to consider other diagnoses and had it clear that they had no contact with anyone with Ebola, had not touched anybody who was sick, had not been to a hospital to visit anybody, had not buried anybody. And these patients were able to find other diagnoses that ended up being something like malaria. But typhoid fever, meningococcemia, or other bacterial infections could be very common in these, and people present with this. Imagine, though, the people in the region, though. I mean, malaria is endemic in these areas. People have typhoid fever, all kinds of other things. And these people, they seek medical care too. So the healthcare workers there are really tasked because they have to, I mean, if you're in that area and you're coming from a community that has Ebola, I mean, the chances that this could be Ebola is high. I remember one of the expatriates who worked in one of these countries, I forget whether it was Liberia or Sierra Leone, who subsequently got infected, said that, well, he was just delivering babies, and in the GYN hospital, OB-GYN hospital, and probably they were not taking all the precautions as they were in the treatment units, but these pregnant women, too, could have Ebola and come down with it. So they just all have to be very careful and just, consider that a worst-case scenario, especially when you have an ongoing epidemic like this in the region. Non-specific symptoms can progress to hypovolemic shock and hemorrhagic disease and respiratory failure, and some patients have to go on respirators and hemodialysis and all of those things, but those are really bad outcomes. The clinical management of Ebola virus disease, again, it is very supportive but aggressive. And by supportive, meaning making sure the patients are well hydrated, making sure you have an IV access pretty early, and you're giving them fluids and pressors as they need, making sure the electrolytes are all balanced, etc. There is no specific antiviral agent that has been developed for Ebola. Of course, it's a viral disease, so you're not going to be giving antibiotics for that. But if patients get complications like pneumonias or bacterial processes, they may need antibiotics, but that's not directed at the Ebola virus disease. Patients, again, can develop, multi-organ failure and renal failure and require renal replacement therapy. Some of the patients so far in the United States have been treated with plasma from patients who have recovered from Ebola. We know Dr. Brantley has been very gracious to donate plasma to several of the individuals that have been treated so far. And that is not a primary means of treatment in the region right now because of some difficulties and sort of in getting the blood and separating plasma and all of these things. But some areas, some of the agencies are able to use that as a means of treatment. So that is available. There is no vaccine yet developed for Ebola. So healthcare providers in the United States, what should we be doing as far as Ebola is concerned? And the CDC, the Alabama Department of Public Health, have been very busy giving us all kinds of guidelines and recommendations on their websites. And we have those. Some of those have been modified and condensed, and placed on different websites around the country. So healthcare providers, if you're interested in finding out, you go to these different websites and you will find out how to do so. The healthcare provider in the United States, CDC, recommends that we do standard contact and droplet precautions for the management of hospitalized patients with known or suspected Ebola. These precautions can be found in the about standard droplet and contact in the 2007 guidelines that you can find on the CDC website. Any U.S. hospital that follows CDC infection control recommendation can isolate a patient in a private room with private bath and door closed, and they're capable of safely managing a patient with Ebola. That's the bottom line. The CDC, the Alabama Department of Public Health, want all healthcare facilities for us to be ready to educate ourselves so that we don't miss a patient when they present to us, so that we have the appropriate demographics, the appropriate epidemiology, the appropriate geography, and coupled with the symptoms, and be able to identify a place that we can place these patients until we have ascertained whether they have that diagnosis or another diagnosis. Infection control practitioners around the state, we all need to be in on this, helping our hospitals, helping our emergency rooms, making triage questions appropriate so that these patients can be recognized early. This is how we're going to protect our staff, our employees, and to be able to quickly identify a patient that will need to be treated, aggressively to prevent him or her from getting sick. They stress the fact that this patient should be placed in a single room containing a private bath with door closed, and there are lots of recommendations about how the healthcare workers need to be dressed and all of that. And we will be talking here today about some of the recommendations for PPEs, which I will just sort of briefly mention as I have some able colleagues here who will go through those for us. We should avoid contamination and reusable porous surfaces that cannot be made single-use. Non-carpeted rooms, remove all upholstery and furniture from there. Use only mattress and pillows with plastic or other coverings. And these are all common sense recommendations. You don't want to have your fancy things inside those rooms that you're going to have to discard and throw away after a patient has left there. Reduce the potential for exposure. Limit the amount of personnel caring for these patients. A lot of places, again, are identifying the number of people who will be involved in taking care of them. A lot of the nurses are volunteering. We know we're using a lot of ICU nurses and people who have, excellent training, and we're doing all that we can to get everybody prepared. Make telephone communication available as an alternative, prohibit visitors with all PPE training and supervision, and there's just a lot of things infection control practices need to gear up on to make available. There have been some new guidelines issued for PPE as of October 20. Again, as we go through them, the recent experience in Nebraska and Emory, as they shared their experience with us, those hospitals have real specialized units, and I'm sure any hospital in the United States does not have the capability that these hospitals have, but there are other things that we can do in order to safely identify and isolate them, these patients and protect them. The CDC has some website that has some training on how to use these equipment, and those will be made available. The Alabama Department of Public Health, ourselves, we are making videos and training videos available so that patients or nurses will be able to use them. There were 3 principal guidelines for the PPEs. There must be rigorous training, demonstrated competency, including the donning and doffing of these material. And the only way to do that is to practice. We have to practice it. Everybody recognizes now that no skin needs to be exposed when the PPE is worn, and we need to have supervisors who are training folks. We want to have the buddy system in place. They talk about double gloving and using of boots. And again, I'm just going to browse over these. You have these in front of you in your slides. And again, they're going to be talked about a little bit more detail. Respirators, including N95 masks or other PARA equipment being instructed, using a full shield that is disposable, and all of these things. Now, no one organization or one hospital, will have, or all of us, we may not have the same things, but we want people to make sure that the things meet the guidelines for us to do. Now, these are pictures of me and my buddy Lynn back at my hospital in Tuscaloosa, Alabama. I had to, again, go through the practice and training of putting on and taking off the equipment. Being an infectious disease doctor, being on the front line in my county and city, I know that I will be called upon to make sure, to help in the diagnosis and or management of these patients. So I wanted to be certain that I knew how to do it too, and so I went through the training to put this on. This is just an example of what is available. This does not mean this is what everybody needs to have. And I also want to say here that my wife saw on our dining room table a list of the procedures in how to put on and take off the PPEs. And when she read them, she called me and said, "Albert, do you know how to do this stuff? Don't come home until you have done it." I said, yes, ma'am. So I made sure I learned it and took some pictures to prove to her that I was trained because I didn't, want her to be upset. So what are some of the PPE practices? Again, select the standard equipment, train and demonstrate competence, designate areas for donning and doffing, train observers, and all of these steps. Again, they're going to be re-emphasized with my other co-presenters today. Glove and hand hygiene, disinfecting of gloved hands using either an EPA-registered disinfectant, wipe or alcohol-based, may be used when using them to take on and put off your PPE. Hand hygiene and removal of all PPE, is important, and we want to do. One of the things that I'm just so thankful, and being an infectious disease person and being in infection prevention in my hospital, and helping all of this, I think this will again make all of us more aware about basic infection control activities, that people will wash their hands more often, that you be concerned about how you put something on and take it off, because it may not be Ebola that we're dealing with, but there are multi-drug resistant organisms out there that can get into our facilities, the Acinetobacters, the VREs, all these things, and we have to do the donning and doffing of these devices in the appropriate manner so that we don't contaminate ourselves or contaminate our patients next door. So this is going to be an indirect benefit that we all will receive when we do this correctly. Patient care, again, there has to be dedicated equipment. Most of them should be disposable and have a place to put them, and follow the instructions from the manufacturers. Medical waste management. There's a lot of recommendations out there about how to handle medical waste. I know early on in our evaluation of what we need to do, there was some confusion. There were companies who were not, they didn't have the authority to transport some of these things, but we have worked with DOTs and everybody involved, and now there are companies out there that will be able to medically manage our waste. Every hospital should be in contact with them, have the units that they can put the stuff in when they can be taken care of. ADEM maintains a list of permitted waste disposal companies, and there's the phone number for those companies, 334-271-7700. So let's all be aware of how those wastes need to be managed. Environmental infection control, the care of the environment. That is one thing, again, but even before Ebola, this is something that every healthcare facility needs to be on top of. I mean, I was at the SHEA conference, the Centennial, a couple of year or two ago, and majority of the talks during that conference was on the care of the environment, because we know that the environment, if it becomes contaminated, if it's not cleaned correctly, that we will transmit disease. I mean, you know what C. diff is doing in our population. You know what you have to do to get rid of Acinetobacter in your hospitals. So environmental care is, the people who do that, they need to be part of your team. Infection control, environmental care people need to work together to make sure that the daily cleaning and disinfection of these places should be done. All the high-touch surfaces and all of those things that need to be cleaned, need to be done well. The staff performance, they need to know how to, put the PPE on, how to take them off and whatnot. And sometimes we find that some of the environmental people do a better job than us physicians and nurses in putting on the appropriate PPE for the patients we are taking care of. So I like to, again, compliment them. Interim guidelines for monitoring and movement of patients, with exposure to the Ebola virus disease. There has been, again, an evolution of these plans from the CDC. There's some new guidelines that have come up recently that I like them, and I think that if we follow those guidelines, we will do well in identifying someone who may become infected and have the capability to infect others. There are patients who, again, if depending on their risk category, they can be conditionally released. The CDC and the airports, the 5 airports that patients from these, individuals from these countries will come from, will be monitored. Every state is going to get the number of patients, individuals who've come from those areas every day, and the health department will have to monitor them for the next 21 days and to make sure they're having phone calls and making sure that they're checking the temperatures and doing symptomatic review over those periods of time. And I think that we, in public health, we have been used to, quarantining or monitoring patients. A lot of that has been done voluntarily in our TB program. That's basically what we do. And only when patients become resistant or, we can't find them or so before we stepped it up. We're now talking about, controlled movements of patients who are at high risk. Those individuals who have a high risk, meaning they were taking care of patients, healthcare workers or so, we're recommending that they avoid any travel on commercial flights that, or ship or train rides, and they do the monitoring every day, and all of that. And I think that this kind of a voluntary mechanism, if people are truthful and conscientious about what their responsibility is, I think that we can control it. What is the ADP is doing? ADP has been on the ball. We have several groups, the epidemiology department, emergency preparedness, our nursing, our pharmacy, our EMS, our lab, dental, communications, and legal. All of these groups have gotten together. They've had planning meetings. We've got documents on our website to help us and guide us through this process. We are actively monitoring individuals who have arrived from West Africa. Just yesterday, I got a call from one of our nurses in Tuscaloosa who had completed the 21-day monitoring of an individual that lives in Tuscaloosa that works in West Africa. And since July, this particular individual has made 2 trips to the region. He doesn't see any sick people. He doesn't go to no hospitals. He does his work in his place. He comes back for his respite. He spends his 21 days. He calls in. I mean, since, of course, the recommendations were made, we have been calling him, and they had completed the 21 days. And he said, Doc, I want you to give me a note to say I'm free. I can go anywhere. And I said, fine, you're free. You can go anywhere. But that's how it's done. Luckily for us in Alabama, we don't have a lot of people that come from this area. They suspect that there'd be 150, people coming per day from these regions or so. And maybe I think we've been getting 2 or 3, on a daily basis. But other states like New Jersey and New York and Massachusetts and Minneapolis, they probably get a lot more people who come from that region. So again, we are participating in doing so, and that was one of the reasons why I had met with my nurses locally at the health department to tell them what's going to be expected of the public health nurse, how we're going to do to monitor these patients when they come. The ADPH has a website. It's adph.org /Ebola, and there's a site for the public that has a lot of information, fact sheets, and all kinds of things there. What's happening with the outbreak now. We have links that go to the CDC website, and all of that is there for our use. There's also a website, there for the healthcare providers that, again, has a lot of information there. It has forms, it has checklists, it has kits and everything for, hospitals and, what to do. So in case you're looking for something there, and we're doing our best to update these, the information on this website as the information changes. So please make that useful. I have recommended to again, the nurses that I speak to, that every nurse should make an Ebola folder. Get your Ebola folder, okay? Put that map in the front of that Ebola folder, and let them, so that you can recognize and remember the names of those 3 countries. And then you have your checklist, the things that they're giving to the travelers who come in, that kit that the travelers get. Have a copy of it so you can be familiar with it and know, what it is. And the questions that the things that you want to find out, that you go on the website and look for it, download it, put it in your Ebola folder. I've got 6 Ebola folders now. The screening of suspected cases, again, this is going back to this form here. What I noticed that this form too has had a transition, because the top thing on the form was the symptoms. We had the fever, the myalgia and all of that. And so anybody who came in and had a fever and whatnot, then people were getting all scared. Then they start to ask the second question, but then they wasted $5,000 already, because they try to work up just somebody with a fever or something. And this is influenza season. That's what's going to happen. These people are going to come with these kinds of symptoms. But if they didn't come from Sierra Leone, Liberia, or Guinea, then just leave them alone. Don't waste their time. Okay, just leave them alone. Do what you normally would do to them, because you will be wasting their time and wasting your resources if you're just, looking for everybody who is sick and trying to pin Ebola on them. Try to find the travel history first, and travel to those 3 countries first, and travel within the last month next, before you start to make a whole big hoopla about this. And I may be sounding like a broken record, but I think it is important, and that's why I am emphasizing this. Reporting of suspected cases. All suspected viral hemorrhagic fevers need to be reported to the ADPH immediately. healthcare providers need to, to know that, to have the ADPH number available. In different cities, different states, probably counties do it different ways. We have in our area have communicated with all the primary care physicians, all the urgent care centers and stuff. We're giving them a little one-sheet thing to tell them what to do. Again, if patient is calling and they're suspected to have fever or come from the region, we are telling them don't let them come to the office. Let them. You call if they meet those criteria, then you call your local hospital. Call EMS and let them prepare to adequately go and transport the patient, to the appropriate place where they can be evaluated. So those are some, things that, again, you do locally to let our healthcare providers know what they need to do. ADPs will use the CDC algorithm to determine whether the patient should be tested, and all testing requests must be submitted to the CDC by ADPH. And this is a reason why, a doctor or somebody can't just call me or call the emergency department and say, I want this patient to be tested for Ebola. It doesn't work like that, okay? They have to meet these criteria, and then you call the state, and then the state calls the CDC. So in my role, as I work for the state, I'm also, I have some local responsibilities, and many of those calls come to me. And so if those calls don't pass muster, I'll look like a fool if I'm calling the CDC to tell them about something that they'll say, hey, Albert, do your, diligence, okay? So please, again, let's all of us as healthcare workers, let us be upfront. We know our criteria well. We'll be confident about it. Let us help to tell other people about it. And so that when they ask us and we know the stuff and we tell them, they'll believe us rather than be sort of shaky about this. Remember that other emerging infectious diseases, the travel history is, again, critical. Let us know about that. The chikungunya, fever, dengue, Middle Eastern respiratory tract symptoms, and enterovirus EVD68. Those are all things that are on the horizon. They're taking back seat now, but they're there. Let's not try to miss them and try to pin Ebola on everybody. But again, I thank you all for the opportunity to be here today and discuss this disease, which I am passionate about because of several reasons, and I want to be one of those who are going to help our healthcare workers in this community, in our state, so that we can be confident to know how to work up a patient, how to not miss somebody, how to make a diagnosis, or have the appropriate person that we want to investigate for Ebola, and then do the right things, let our hospitals be prepared, our emergency departments be prepared, so that we can identify them and protect them and then give appropriate treatment to them. So I'll stop here. And hopefully there will be time for questions later on in the program, and we'll be available to answer them. Thank you for asking me to participate this morning.
Thank you, Dr. White, for an excellent presentation on Ebola 101. I have a couple of questions. One that had been submitted in advance was whether or not Ebola has any carrier status, and there was a question in the context of some of the other viral infections like varicella that later can cause shingles, or HIV, which is the ongoing presence of the virus. So could you clarify for our audience?
Well, as far as we know now, there is no carrier state for Ebola. It's not, it's different from HIV. HIV sort of persists, and we have several cases to know that when you stop treatment, the virus will return because they persist in lymphocytes and things like that. And, VZV, persists in neural cells and neural tissues, but there's no evidence that Ebola has any of these cells that they persist in. And like some other viral infections that you eradicate, completely like smallpox or measles, when those viruses go through their stages or their process, the people, some of them get immunity to it, and they do not, they are protected from getting infected again. So as far as I know, there's no carrier state with the Ebola virus, and that once you eliminate it or you go over that acute phase, you develop antibodies or so, and you can remain protected for a long period of time.
Thank you. And one other point I'd like to get your thoughts on is one of the slides, and you presented this, but CDC has said that any hospital should be capable of managing a patient with Ebola. And I want to sort of talk about that a little bit more, because that does not mean in an ongoing way that if they had an identified Ebola case that they would continue to provide services. Perhaps a rural hospital would want to know where that line was drawn.
Well, again, I think that, preparing, and because, people who travel, they go anywhere. They're from any city in Alabama or in the United States, and they show up. So I think all the emergency departments of hospitals need to be aware, need to modify the screening to identify someone who may be at risk, have a place either near the emergency department nearby where they can place that patient, private bath or so. And then when they contact the state and we see that, yes, this patient needs to be, will meet the criteria, needs to be tested, we're going to do the testing, send the bloods off to the CDC. If that blood is confirmed and we have a case, then as we see, the CDC said, well, within hours, they will be sending a team to that particular hospital to make some assessment to find out whether this hospital is ready, they have the capability to take care of this patient if this patient gets, because over the next several days now, there's the potential for that patient to become sicker, before they either recover or if they succumb. So at that point, the CDC will make that determination to decide where this patient should go. I understand that there are some states that have already designated certain hospitals. I hear, like, for instance, New York, I think they said that Bellevue, one of the hospitals that this particular physician from the Sierra Leone is currently in, had been designated by the state as one of the hospitals that would take care of those patients. The CDC has also, in other instances, have transferred patients from a hospital to the NIH or from there to Emory. So it all, again, depends on how prepared the local, state, and that region is about what will happen next. And if it's just, a little small hospital in a small town or so, and that you have a 2-bed ICU or so with, not a lot of stuff to take, that probably that hospital will not be required to take care of that patient, and they may be moved somewhere else.
Thank you. Do we have any calls or questions, email or by phone at this point in time?
Well, I have a question. Dr. White, you and I have spoken about this, but can you comment on if you have been exposed, high risk exposure, and you're in your 21-day period, just because your blood test is negative one day doesn't mean that you are not going to get Ebola. You could actually be positive the next day. One negative, two negative tests don't mean that you're negative.
Well, as you see, the CDC has been trying, again, not to test someone until they become symptomatic, because the chances of you having a positive test on an asymptomatic patient is so high. Now, there may have been political pressure or something for someone who is not symptomatic to be positive, but that's not what the science says that you should do. So if the patient is not symptomatic, you're wasting that test to test the person, because if that was possible to detect someone before they were symptomatic, then that would be the best thing to do at the airport. Just test all the 150 people that come in, and then you pick somebody up. But because we know that that is not possible, that's why they're saying wait until the person is symptomatic. Now, there are instances too where someone may become symptomatic. They got a little chill or cold or something, and they have the right epidemiology, and then you test them, and then, well, maybe they got a cold. Maybe they've got something else. That's why they had that little symptom. It doesn't mean that, because you had a heart, you were from the area, now you got a cold, or now you have a little fever, that is going to be Ebola. It may not be Ebola, so if they're symptomatic and they're throwing up and they're vomiting, and you test them and they're negative, they're probably negative. They ain't gonna turn around and get Ebola. They've got something else right there. So I think avoiding testing, asymptomatic patients will be the way to go. And if they're symptomatic and they get tested, then and they're negative, then try to find something else, because they may have malaria, typhoid, or one of those other things that we talk about.
And what is the test that they do? Is it like an IgG or something like that? What is the test that they actually do?
There are several tests that can be done. They're doing a PCR test looking for the virus antigen itself, because those are the things that will come in early. If you try to do ELISA to look for antibodies, that will be later in the disease that we found. So the tests are geared to find the antigen, to find the virus itself. And that's what is being used. And that's not a test that just any old lab can do. It's more of a specialized test.
Dr. White, is it true that if I have a patient that just came in and had their initial symptoms started less than 24 hours ago, that if they meet the requirements and the state approves testing and it's submitted and it's negative, is there a recommendation for to repeat that test?
Yes, I think there's a recommendation to repeat that test if they're if they're asymptomatic. I mean, if they're symptomatic, they meet the right criteria, and it's early on, within 24 hours, they may say repeat it. But at that same time, then when you do that first test that's negative, then you start looking for something else. Now, make sure you do your malaria smear. Make sure you do, to start saying maybe could be something else. So after another day, a third day passes, and you test them again, they're still negative, then it's unlikely that they have Ebola.
Could you give us, Dr. White, some examples of the other tests that should be done when you have somebody presenting that you are evaluating that meets that travel history, first of all, and then they also meet the symptoms? What are the tests that are recommended to be done on a person that's being evaluated? Well,
I think a CBC would be a good thing to do because, for instance, if they have a very low white count, so they may have a viral illness, other virus illness, like now, they could have influenza, and you might want to do a flu swab. And definitely I would want to do a malaria smear. That's a blood film. You can send that down to the lab. They can look at it, stain it, and they will see parasites, on there. Now, there's the rare possibility that somebody could be coming down with leukemia or, something else, but that may not be related to the travel or whatnot. There's not a specific test you can do for dengue. I had that question, when this person came and they were negative for Ebola, they were positive for malaria, but they wanted us to do a dengue test. And I said, well, there's not it's just go again on the epidemiology. If you've been to an area, been bitten by the mosquito and all of that, and that's a different, route of transmission than Ebola is. So again, depending on, if they're coming from West Africa, I would be doing a CBC. Now, if they got a white count of 23,000 and they've got some vomiting and some diarrhea, then I'll be worried about typhoid or hepatitis, all those things that have an abnormal LFTs. I want to do LFTs too to see that I don't miss, hepatitis A or B or typhoid or malaria or a viral process.
Thank you. Any other questions from the audience? And since we don't have any electronically,
I do have one. I'm sorry, Dr. Miller.
Okay.
A question from here. How long does the virus live on surfaces of an object, and does it live longer in cooler weather?
Well, I've heard several different answers to those questions, that the frame at which the virus lives outside the body could be anywhere from 24 hours to several days, again, depending on whether it's in moisture or whether the temperature is appropriate. If the place is dry, there is no moisture in that area, and the virus, the lifespan is short. So that's the only information I've been able to answer that so far.
That's all.
Well, we have seen the first hour fly by, and we really appreciate the information that you have shared, and it's obvious to see that you have a passion and a commitment to this issue. And we are now going to take a break, 10 minutes, so they'll set the clock, and we will see you again in 10 minutes.
Hello, this is State Health Officer Dr. Don Williamson. Rumors about Ebola are plentiful, so be sure to get the best and most reliable information possible. Ebola is not a new disease. However, it is new for healthcare providers in this country. We're working very closely with hospitals, medical providers, the Centers for Disease Control, and others to provide the latest and best information available. We publish this information on our website at adph.org/Ebola. If you have questions or concerns, please visit our website.
Welcome back to our presentation on Nurses Matter, Ebola 101 and Personal Protective Equipment. What you just saw was a PSA that we've developed from the Alabama Department of Public Health, one of many in our portfolio that we're rolling out, and that one actually was released statewide to the media this morning. Look for more of that to come. I wanted to make a couple of comments about the presentation today, starting with the title that nurses do matter. We see the nurse as a critical player, and in many ways the main player when we look at all the challenges to this country's healthcare system around Ebola. Nurses are on the front line, whether it's in the triage area, at the emergency room, whether it's providing the bedside care to the patient. So we want to say an especially heartfelt thank you to our nation's nurses and our nurses here in Alabama for all they do on a day-to-day basis, and even more so as we look at preparedness efforts around Ebola. I also, for the second part of this presentation, want to say that the folks that are joining us, Patty Miller, who's Infection Prevention Coordinator at Baptist Medical Center South, and Cynthia Murphy, who is a nurse and the Director of Clinical Education at Baptist Medical Center South, work at a facility that is representative of what I would call a community hospital. It's not one of the large academic centers or one of the centers of excellence that we see in either Emory or Nebraska. It's more what we see all across the state in terms of doing the day-to-day work of providing health care to the communities. So I think that's going to resonate with a lot of you in the audience listening and viewing today. So with that, I will turn it over to Patty Miller.
Thank you for letting me participate in this program today, Dr. Miller. And I would like to talk about our facility and our experience with a possible Ebola patient. First, Baptist Medical Center South is part of the Baptist Health System, which is a faith-based organization operating a multi-facility healthcare system located in Montgomery, Alabama, providing healthcare services to the residents of Central Alabama. Baptist Medical Center itself is a 454 licensed beds. It's a tertiary referral center for Central Alabama. It employs 2,000 plus team members and is known for its outstanding cardiovascular, orthopedic, neurology, and surgical services. The second slide is I would like to give heartfelt thanks to our infectious disease physician, Dr. Jody Samant, who is our chair of our infection control committee, as well as being an assistant professor of medicine with the section of infectious diseases and internal medicine of the UAB School of Medicine located here in Montgomery. She was our Ebola leader, our Ebola team leader. She was the first one to get us on the right track. Even though she is 7 months pregnant, she donned the personal protective equipment and went in and stayed with that patient that we had, as well as Cindy Murphy here, as well as Sherry Harrell out in the audience, to make sure that we took care of that patient. And one of the main goals of all of it was not only to take care of that patient, but to make sure that all of our healthcare workers were protected as well. So, I'm going to talk about our event that happened on October 17th, but first I want to let you know we had a team meeting. A couple of weeks prior to that, we were revving up for the flu season. And then all of a sudden, Mr. Duncan shows up in Texas, and our whole plan, just like probably most of the countries across the hospital, had to shift gears into fast track to make sure that we would be able to take care of an Ebola patient. So prior to this date, our team had been meeting. We had selected our PPE. The PPE that we were using was actually what we had in place and it had been supplied by a grant from the Alabama Hospital Association. And so we already had some PPE, which has been modified since then, but that's what we had at that time. We had selected our location for our Ebola quarantine area. It was in a unit that had a separate air supply. We were able to have an anteroom, have all of the things that are necessary to take care of that patient, as well as it being not in a main patient care area. Not to say that everyone else has the opportunity to have a separate area like that. Although it was in our hospital, it was not with other patients. So on this date, October 17th, we had a phone call that was received with a potential Ebola patient coming to Baptist Medical Center south from a local eye clinic. So this is what happened. We had multiple phone calls from various sources. We were hearing from the Alabama Department of Public Health, the emergency department, the safety officer. He was being called by the Montgomery County Emergency Medical Service. And then the emergency department was calling the director of emergency services, the house supervisor. They were calling me. I was talking to the Alabama Department of Public Health and the safety officer. And then the director of nursing services notified. And as we go along, it just continued. And so that is one of the first lessons learned, was that we needed to have better communication, not only from the outside, from the EMS service, but in our facility itself. So we'll talk a little bit more about that when we get to the lessons learned. So then the safety officer notified our facilities management. So the area that we used is actually an outpatient infusion center. So we had to clear the patients out of that area, as well as to set up our Ebola quarantine unit. We had already walked up there, realized that we could accomplish what we needed with negative pressure. We took actually 4 rooms out of that infusion center and set our area up. Now that area is set up. So if we have an Ebola patient today, we have an area that we can go to. But at that time, it had to be set up. So because of that, and with communication with EMS, we realized that the patient was okay and stable, that they could stay in the ambulance until the quarantine area was ready for the patient. We had a language barrier with that patient, so we brought in actually a person to help with translation. This patient was actually from Nigeria, had not been there in a long period of time, but there was a language barrier which I think was part of the confusion from the very beginning. So it was a team effort for our quarantine area to be set up. We got negative pressure, we got the supplies up there, we prepared the room, the PPE was prepared and kits were checked. And then they started donning and doffing, practicing before that patient actually arrived to our area. So everyone that went into that room had practiced donning and doffing of the equipment. There was a site manager was assigned to be the buddy. The EMS brought the patient to the designated entrance to the facility, and in our prior planning we had decided that we would not take them through the emergency department. If we had a true possible case, they would come to an entrance to the hospital, which is not one that is an actual entrance for folks to come in and out of. That patient was met by our infectious disease physician and our director of the emergency department and transported to the quarantine area by the response team members. One of our lessons learned is that there was a lot of phone calls going on. And because the press had been notified, people were getting all kinds of, our staff members had no idea what was happening. So we bring the patient in, and security had not sealed that area, so that was a lesson learned as well. Because there were other staff around, as we traveled that one hallway that we had to get that patient to that area. The evaluation was completed by the infectious disease physician and was recorded on the ADPH form. Patient was evaluated as negative risk for EBD per CDC screening tool. The findings of the CDC evaluation tool were discussed with Dr. McIntyre from the Alabama Department of Public Health. Forms were faxed to them for review and clearance of the patient from isolation. Once we got clearance from the Alabama Department of Public Health, we then also got clearance from the Baptist South Administration. We worked very closely with the Alabama Department of Public Health, as well as working very closely with Alabama Hospital Association, and appreciate their efforts in helping us during this time. So these are the lessons that we learned. All staff should be aware of the Ebola plan. We had just released the Ebola plan on Thursday, October 16th, to our management staff and our personnel. And then we get the phone call on Friday. So we went in fast gear to enact our plan, and I'm happy to say it worked. The EBD alert should be activated by infection prevention practitioners after consultation with infectious disease and communication with the Alabama Department of Public Health. We decided that we need to have an instant command center, should be opened immediately. We also are working with the EMS to make sure on the other side, pre-hospital, there's cooperation going on there as well, so that that was another lesson learned, that we could better communicate. We want to implement the phone tree. We have updated our phone tree so that we don't have just one person, but we have an alternate for each person that is on our team. And we are now looking at a mass communication system. When it's decided that we need to set up this alert and send out that communication, it can be sent out as by mass communication devices. We want to ensure the transition of care is completed, including the vital signs, before that patient arrives at the hospital. So that is, there was such fear at that time and lessons learned that we would do a better job this next time around on our side, probably also on the other, to make sure that that transition of care, we, as we said, take that history and physical, make sure that we look at those, did they come from one of those countries in West Africa? Just as Dr. White had said, this is very crucial so that we don't set up our rooms and we don't spend a lot of time if it's not really necessary. We need the hospital security involvement and assignment. As soon as the EBD suspect alert is triggered, then the security, our hospital security needs to block the route. The patient will be transferred to the quarantine area. And then we need to determine Ebola team members or volunteers. We are very fortunate in that we already have 34 volunteers from our staff and that's just nursing, that have volunteered to be part of our Ebola team. We also have environmental services personnel that have volunteered to be part of our team. I think one of the keys is that once they realize that they can safely take care of that patient and you calm that fear factor, then that is definitely going to help. We have now have equipped our Ebola area so that we have the negative pressure boundaries. At the time that we had our incident, it included more area than we actually needed. So we now modified that. We put a window in the door of where that patient's room would be. We have an intercom to eliminate handoff, communication of documentation. We also have a camera to monitor the staff in the room with the patient. We have the hospital green scrubs are in all sizes, are now stocked in our room. And we also have washable shoes that should be available and are now stocked in that area as well. We looked at what we needed to put in that patient's room, and so we now are looking at the bins, like respiratory therapy has a bin that has all of their supplies in there, the typical supplies that you would need for nursing of that patient. And these are other things that we would have located in that patient's room. Instant hand sanitizer, other patient personal hygiene items, environmental services. We put disposable mop heads in there, disinfectant, bleach wipes, double red bags and special waste receptacles. We have actually gotten the large drums and have the large meal red bags. We have acquired those and they are on site. We do have a bed with a disposable mattress. We have the linens, heating and cooling blanket. And as I just stated, we have that category A waste container. So we have the EBD quarantine unit that is fully equipped, but then we also have to look at what we're going to do if we have a patient that doesn't come by ambulance or as a direct admit from a physician office, because if we have one come from a physician office, they'll automatically go to our quarantine area and would not go through the emergency department. We have designated an area, a triage area, in our emergency department. And we also have the isopod, which is that enclosed patient containment system that was used that day. We have updated our PPE supplies. Lessons learned from the use of the PPE, I'm going to let Cindy talk about that in her portion of the program, but we did find that the gloves, we needed the extended cuff of gloves for better coverage, impermeable gowns, impermeable hood, long face shield for better coverage, and longer shoe and cover combo. The PPE that we used, as I stated, in this incident is not what we would use today. We used what we had. We were fully protected, but we have now modified it for those with easier use. You will not see our PPE today because we are on national back order for the hood. So we are still awaiting getting our hoods in before that we can actually do training or actual physical training with that. And plans are, I believe, that we will do that at a later time along with the Alabama Department of Public Health when our equipment is available. We do have PAPR hoods, but we would not use them in all circumstances, and rubber gloves for environmental services. So we need to identify, train, designate our unit and site managers, have the logbook with the following PPE near the following information near the PPE cart, and listed there is what would need to be on that logbook. An immediate notification of any breach in protocol would need to come to infectious disease and the infection prevention practitioners for discussion to determine the plan of action based on that exposure. Healthcare would not be released until assessment of the exposure is made. We realized that we really needed to get our plan out there, although it's still under modification. It may be again as time goes on, but we are updating our plan as things develop. We required the required PPE list and donning of the PPE and instructions are in the cart, and also we are putting signs up in that area, large signs, to show how to don and doff the equipment. One of the things that we looked at too is the food and nutrition. We're going to use disposable cups and trays, and we wanted to make sure that our staff is well taken care of regarding drinks, snacks, meal arrangement, and if necessary, dependent on the situation. One of the things that we also learned is who's going to take care of that patient's personal belongings, because that was another issue that we had, is that some of the patient's belongings were left at the site. Some came to the hospital with the patient, so we were working with the EMS and ambulance companies to make sure that their equipment, their personal belongings are bagged and kept with the patient. We have listed the services of infectious disease. They will be our front runners and would be consulted on all EVD cases. We have the hospitalist service will be utilized for patient admission as needed, and we actually have already obtained volunteers for that. The ED physician services will be utilized if notification is obtained that the patient is unstable. We have a volunteer in the ED physician. Critical care services will be utilized if the patient is intubated, and the plan for transfer of the patient to a higher level of care, most likely to Emory after the lab confirmation by CDC. We've been very fortunate in getting volunteers, physician volunteers as well, to help with this. Nursing services will consist of the site manager, one med surg, one critical care nurse. The mix of the nurses will be determined by the severity of the patient. A maximum of 1 hour in the personal protective equipment, and that could be modified if the equipment, due to the modifications in the equipment that we have made. The buddy will help with the donning and then will take over the patient care. Determination of the number of hours for each shift. Standardized training for all unit managers, some ED nurses, critical care nurses, and floor nurses. Staff volunteers, and maximum number of shifts can be modified based on the clinical condition of the patient. One of the main things that we want to do, and I think Dr. White talked about this as well, we want experienced staff to be the ones that would be taking care of that patient. We want, for PPE training, standardized training with associated competencies. Education and the infection prevention practitioners will do that training. We also are going to train our physician group. Nurses will be trained in phase 1, and then volunteers, the nurse managers have been trained, and then in the second would be our volunteers. Ancillary groups, we would select volunteers from each one of these areas, such as respiratory therapy, radiology, microbiology, and environmental services. Future considerations is ADPH, emergency preparedness for the community. We want to work in collaboration with Alabama Department of Public Health as well as Alabama Hospital Association to get this dissemination of this information out to the community. And then also funding is a consideration. And when we talk about expenses, we talk about supplies. We have not made decisions, but we've looked at what to do with staff, appreciation for the effort, rewards for encouragement. And we are also looking at an off-site dedicated infectious disease unit that would be located close to the hospital but not actually in the hospital, where we could house this patient on an emergency basis, not just for this infectious disease, but for any infectious disease we may encounter in the future. One of the things that happened with our incident is because of the fear factor, we had 25% less admissions to our emergency department over that weekend, as well as we had patients that wanted to leave the hospital. I agree with Dr. White. It's so very important that we calm the fears of the public about this disease and realize this is just another infectious disease, and if we protect ourselves, then we certainly can take care of our patients as well as all of our staff. I'm going to now turn it over to Cindy Murphy. She is our Director of Clinical Education here at the hospital, and she's going to talk about preparation and protection.
Good morning, and thank you for allowing me to be part of this. Thank you, Patty, for turning it over to me. I'm going to talk about preparation and protection. And one of the things that I think everybody has to acknowledge is that there is a huge fear factor associated with this. So The contributing factors to that fear was just the changing recommendations on our protective gear. It was changing daily. So when we had this incident, we did have nurses who were very fearful. And they were also just afraid of the unknown. We had never taken care of an Ebola patient, so they were obviously fearful of that. So how do you overcome that fear? For us, it was to simply acknowledge it. We knew that our nurses would be fearful at first. And then secondly, we needed to embrace that fear because we knew that healthy fear is good. And healthy fear can make you cautious and it will keep you safe. It does not need to paralyze you. It needs to be part of who you are and to make yourself be prepared for it. The last thing we did was to overcome it. And we did that through enhancing their knowledge. We needed our staff to know about Ebola, and we also needed to train. And that was the key to our success. One of the key things, and Patty alluded to this, is that it is another infectious disease. And we take care of infectious diseases every day that we work. So this is nothing new. So we know how to do this. There are probably infections that we don't even know about yet. So to be prepared is to learn about it and to understand it and to learn how to apply your protective gear appropriately. One of the key things I would recommend is that you allow your staff to get comfortable with the donning and the doffing processes. This is uncomfortable when you start doing it, so they need to see that it is a little tricky, and they have to do it over and over again. So allow them to do that. And I would suggest that if you have already identified an Ebola place in your facility, let them do it within that Ebola unit. That was key for us. We took them on tours of the area so they could see exactly where the clean areas were, where the supplies were, where the dirty areas were, so they would understand it and they would get comfortable within that area. We also allowed them to do that so they could learn how to communicate from within that area. So we realized quickly with our incident that we had communication barriers. So we implemented using the nurse call system. So we didn't implement or put anything new into place, but we have the nurse call system on the whole time so the person in with the patient does not have to chart. They would be talking to the patient out at the, not the patient, but their buddy out at the desk, so they would be documenting for them. It's very cumbersome in full gear to try to type on a keyboard. We also didn't want to put expensive equipment into the rooms. So this was how we overcame that. They also needed to know how they were going to chart and deal with that, because it's second nature now for nursing to use computerized systems and document while they're talking to the patient. Now they're actually talking to their buddy. So it was a learning experience for us. This is just examples of protective gear. We did have the face shields, but we also knew that they were shorter than what we wanted. So after our incident, we ordered longer ones, so I would suggest that you do that in your facilities. This is an example of a PAPR hood, which we do have, but as Patty said, we're not going to be using the PAPRs until we need to. This is the hood that we are awaiting arrival. You notice that it covers the shoulders, which would cover our gowns, and that's what we have decided to go with. These are the foot and leg protective gear. Initially we had just boots, so they did not go up to the thighs, and we felt like we wanted to cover as much as possible, even a second time. So the gown is going to be covering this, but the long legs is what we thought was needed, and they're very easy to take off. This is the gown that we will be using along with the gloves. We will also be using an N95 mask associated with this, so you do not see the hood on this example. So what do we need to do for training? Competencies is huge. So we have developed competencies, and we would be glad to share those, so you don't have to recreate those wheels, but please adapt them to your organization. Develop them, practice with them, and train to your competency. Don't skip steps, and that's key to your staff. Repetition is key to being prepared and being safe. Repetition, do it over and over and over again. The first time people put on the full protective gear, they were antsy about it. It was like, I don't know. And by the fourth time, they were like, I got this. So allow them to do that and allow them to get comfortable with it. Make your training fun. One thing that we did was we used chocolate syrup. So once they were in full gear, we put chocolate syrup all over them, and they had to get out of it without contaminating themselves. It went over huge. They had a great time with that. So make it fun. It will also diminish your fear. So they will see when they pull off a gown, oh, chocolate got on that last pair of gloves. I would have been contaminated. So it was a great learning experience. And remember to do ongoing training. The one thing that we were concerned about is we're going to train, and then you may not see a patient for 6 months. So we're going to continue training for our volunteers especially, but any nurse or any respiratory therapist, any healthcare worker who wants to come in and see it, we're going to allow them to do that. We also have site managers. So we have a buddy, and then we have a site manager. So there are 2 people at all times, one in the room with the patient and one outside, in addition to your site manager. So I wanted to talk to you for a moment about the role of a site manager. The main thing that site manager is there for is to keep your staff safe. Make sure going into the unit that they are safe, putting on their gear, and to make sure that when they take their gear off that they remain safe. The site manager should be a very calm individual. So allow your person to see their people, to see the equipment, and see how they react with high intense situations. So make sure that they're very calm. Be slow and deliberate when you are talking to them about putting on gear and how they're taking their gear off. You would be surprised how quickly people want to not remember the appropriate way to take off dirty gloves. So talk them through it and tell them stop. Don't take it off until we go through it together. And they do a great job with that. Also ensure that your documentation requirements are completed. And those consist of competencies before they ever go into the room. So if you don't have somebody checked off, they would not go in the room with the patient. Also, we have an employee logbook for Ebola, which in the previous slides it talked about. It's the name of the employee, the time they go in, the time they come out, plus the sequencing of the protective gear that they're putting on. You would also watch them take it off, and if you suspected any contamination whatsoever, that's when it would be reported. You have to remember, as the role of a site manager, that you are the expert. They are looking to you to calm their nerves and to ensure that they're being safe. So always follow your evidence-based practices. You are the trainers of your staff, so make sure you know it thoroughly. And then talk your staff through the donning and the doffing. So don't let them rely on memory. Always talk them through as they're putting on and taking off. Lastly, I'd like to talk about trust. You have to trust in yourself. You have to trust in the knowledge that you know. Educate yourself about this disease. The more you educate yourself, the more you're going to be comfortable with what you're taking care of. And remember your basic skills and training. Also, the training. Trust that training because you did go over it over and over and over. So allow that memory to come into play, but know that your site manager is going to be there. You also have to have that trained observer there with you to ensure that you're doing it right. So nobody should be going in and out of rooms unless somebody is monitoring that. Also, trust in your processes. We trusted fully that our Ebola plan was going to work, and it did. We trusted that the buddy system that we had implemented was going to work, and it did. We also trusted that the steps were the same, and it has to be that way every time. You cannot skip steps. Lastly, we trusted our leadership. At Baptist Medical Center South, our aim is patients first, compassionate care, and pursuing perfection. We trusted our leadership. They were with the media, and they were handling that, and I was so thankful that we didn't have to worry about that, and we had Alabama Department of Public Health with us side by side in doing that. So we had to trust that. We are a community hospital, and we took care of a person in our community, and that's what we do every day. So we need to continue doing that. We also trusted in our team, our colleagues, and we trusted that everybody was doing their job. We had to know that negative pressure rooms were going to work. We had to know that supplies were going to be brought to us. So trust in what you have surrounding you, and know that you are a team. You're not in there alone. Thank you for letting me be part of this.
Thank you. Excellent job to both Patty and Cindy, and we appreciate you sharing that information. Just to summarize, you are what I would call a very vibrant, quality-oriented community hospital that was developing an Ebola plan, and then you had the experience to receive a patient who was of concern, and that helped you not only put that plan into place, but to come out of it with a lot of lessons learned.
Absolutely.
And I think you've shared that obviously a plan like that is a work in progress. It will be modified. You had future considerations, but obviously you're going to continue to tweak it, crosswalk it with CDC recommendations and minimum standards.
Absolutely.
And certainly move forward in a continuous improvement sort of mode. So I really appreciated that information that you've shared with us that sort of makes it real. Do we have any questions?
I do have one here, and I would remind people to please either call us or email the questions in. The lines are open. We have a question from one of our emergency preparedness partners, which is an Alabama State Trooper. I was wondering what your protocol was for disposing of PPE from EMS or police officers that have come into contact with a potential Ebola patient. Would you as a hospital take them, or would the individual agency have to dispose of them themselves? If yes, how would you like the exposed PPE to be presented to you, double bagged, for instance?
I believe.
Yeah. I think that's one of the areas we're working with, and we're working with every domain you can think about where people go, because this can be a situation, especially for law enforcement, emergency responders. So we're working on all of those very granular questions because they're real, and if we have a situation, they're going to have to be addressed. So similar to what you guys are doing with the planning, we are working through the steps and the recommendations. So I'm not prepared right now to answer. Dr. McIntyre, would you add anything to that?
We are preparing it. I do know that EMS has already provided guidance as far as what to do. They have a process in place to actually go through a decon process, how to do other things as far as with their staff. So it is one of the areas that we're working through. They specifically will deal with their own when it comes down to the decontamination process and getting rid of the equipment.
But at the end of the day, hopefully you will have answers to those questions and some very definitive guidance on what to do in that situation. So do we have a phone call?
We do. We have a call from Birmingham.
Okay. And caller, are you on the line?
Yes, I am on the line.
Okay.
My question is, first of all, I'd like to congratulate the Baptists for the fantastic job that it seems that they were doing in getting a plan together. But my question is, did anyone do, on the patient that came in, did anyone do a travel history on the patient to find out perhaps that the patient was from Nigeria, and perhaps that the plan did not need to be utilized because he was not from an area that, would put him more at risk for the Ebola?
Would you like to answer that, or would you like me?
You can, and then
Okay.
I can.
And I can talk with Dr. McIntyre with this. We got the original phone call from the EMS that they were transporting this patient to us. I think that the fear was so much there, and there was a language barrier, so that those questions that ordinarily would have been asked were not asked. And there was some discrepancy between what the patient said about her family history and what was actually the case. And that was discussed. Dr. McIntyre, would you like to answer this?
The answer is that they asked questions, but they were not secure with the answers,
Right.
which means that the people that were there and on the scene, okay?
Right.
And so we have to go back to the thing about trusting people who are responsible for doing their job. So they were acting on the information that they had, and that information was conflicting. There was some question as far as whether or not there had been an exposure to somebody with recent travel from an area, not Nigeria, but from one of the other areas. And so part of this, and this is like we said, it is a process that we're going through, and there have been additional recommendations that have come out even recently that talks about maybe lowering the level of response and the level of PPE when we're dealing with people that are not really ill, which they're not throwing up, they're not really symptomatic per se, other than they may have a low-grade fever, so that we can do some things to try to hopefully minimize that in the future. So we're working through that.
And we also are meeting, our safety officer and I did meet with the EMS, so they sort of did a lessons learned after our experience, and Alabama Department of Public Health was there, as well as EMS, as well as a lot of folks. And it was determined that they would need to set up an instant command, and that they would need to validate the information before that phone call was made that we had a possible case. I think this was good lessons learned, and it was a wonderful training exercise for the hospital, and we're very happy it happens because we realized that our plan worked. But it has afforded us a lot of opportunity to work together collaborative with all of the people concerned, pre-hospital as well as those of us in the hospital system, to improve that whole system.
And we do, having worked with EMS, there's actually been recent guidance that's gone out just within the last few days that actually makes sure that there is a network that stuff gets filtered through to kind of help with some of this.
So I think in summary, the overall process, not only the individual players, be it EMS or the local staff at that clinic, as well as the hospital staff, collectively and individually looked at this as an opportunity for lessons learned,
Right.
and how do you invent a better approach over time. And again, that's the nature of what we are doing as this continues to unfold. It was new. It's a lot of that upfront kind of angst and fear of the unknown is gradually, as we move along and learn more and get a little more experience, exposure, and practice, in your case, helping to mitigate some of those things. So another call?
We do. We have another call from Dothan.
Caller, you on the line?
Yes.
Go ahead.
This is Donna from the Medical Center in Dothan. I wanted to find out if your plan includes a standard order set for the Ebola patient.
No. Dr. White,
No.
do you have one?
This is Dr. White, and just to comment on that, I would say again, emphasizing that the basic treatment for the patient with Ebola would be supportive care, and the treatment will depend on how the patient presents, how sick they become, and what the transition. We also have the experience. We know that a couple of the nurses, from Texas who have recovered already. Although I was not involved in their care, but it appeared as if they did not get significantly ill, requiring intubation and all those things, and they got well pretty quickly. So I mean, you can't go say, "Okay, fine," everybody's going to get hemodialysis if they don't need it. So it's going to be just being sensible and noting what they want. Some of them, if they don't have a lot of vomiting and diarrhea, they may not need IV fluids. They can, rehydrate themselves, orally. So it all depends on how sick they become and how you step it up. And again, we're hoping that a community hospital, a small hospital, will not be saddled with someone who will end up needing invasive treatment and all of that. And that centers that are more used to having that and have the facilities will be able to handle those kinds of patients. So I don't think per se there's a standard order set. We talk about some of the laboratory work that needs to be done, things like a CBC, LFTs, an INR, PT, platelet counts, and all of those kinds of things would be basic things. And then your physician, your hospitalist, or your infectious disease person, or whoever is going to be the admitting physician, will then determine how to step it up if it needs to be done.
Thank you, Dr. White. Another question?
We have a caller on the phone from Tallapoosa County.
You're on the line.
Hello.
Hey, go ahead.
Hi. Yes. You mentioned earlier that, or someone mentioned that there were different procedures and plans being developed. Are there plans being developed for our public schools? And if that's the case, when do you think we might find out when they will be in effect?
I can answer that.
Dr. McIntyre.
This is Dr. McIntyre. We actually have been working through and working with the Department of Education. We also have been working with the colleges and universities. We've got toolkits ready to go out and information to go to the superintendents, to the chancellors, and I believe that information is going out this week if it hasn't already gone out. But we've been working on it for some time, and it is ready to be distributed.
And I would say from the federal level, just yesterday, dated yesterday, the CDC posted some new information, resources for parents, schools, and pediatric healthcare professionals. So folks at a lot of different levels are working on these different, again, domains, including public education, colleges and universities, and other educational institutions. So I want to, if there are no more questions at this point.
I do have
a few
that have been emailed in.
Okay, we may have to get to some of those individually because the time is. Are we okay with the time? Yeah. Okay, go ahead, Val.
First of all, was there a dedicated satellite or point of care lab used for monitoring? If not, how were sample containers disinfected?
We actually have all the laboratory equipment up there at point of care. Since we did not have an actual Ebola patient, then we did not have to worry about that. But it is in our plan that if that is the case, that the microbiology personnel will be the ones to go and package that have been certified to package the specimens to be sent to the Alabama Department of Public Health and on to CDC. We do have the supplies up there to make the malaria smear. We do have the iStat located in the Ebola quarantine area.
Okay, and last one that I have, actually I got a couple more. What of the possible pregnant patient that goes into labor, being in personal protective equipment to negative pressure room, L&D staff training?
I'm confused.
Yeah, the same concerns would be present for a pregnant woman, and there's been a lot of recent guidance that's been developed by the American College of Obstetricians and Gynecologists within the past couple of weeks that's been released, and that is likewise available on the CDC website. But you have the same, there are no more, no less concerns in terms of infection control and PPE and so on.
And we have volunteers from labor and delivery, women's services, and pediatrics. So we covered the gamut to ensure that no matter what kind of patient came in, we'd be able to take care of them.
Okay. And last one that I have, how long will we have to be on high alert for this disease transmission in Alabama or the U.S.?
I think that's a crystal ball question because, you know, it could present tonight, or even while we've had this satellite, it could be rolling into an emergency room, a outpatient facility. Nobody can predict that sort of thing. What we do know is that to be vigilant, to be prepared, so that if it does happen, you control it and contain it. That's the way we're going to end up. As Dr. White pointed out, 2 countries that had what's not an insignificant number of cases now are off the list because of that early recognition and the standard public health control measures. So, again, nobody can answer that question at this point in time, but we all hope it won't be too long. So.
Dr. Miller, I did have a comment to my fellow nurses throughout the state, in the United States. Only 50% of healthcare workers take a flu shot every year. Every year, 30,000 people in the United States die of influenza. Only 35% of nurses take a flu shot. So I would encourage my fellow nurses, if you're serious about your patients, take a flu shot.
Well, and I would second that. It's a recommendation that healthcare workers strongly consider that based on the setting that they're in terms of potentially infecting not only patients but also co-workers. And you have a special connection, I think, when you're talking about Ebola, because a lot of the symptoms for flu can mimic those of Ebola. So this is a message in particular for healthcare workers because of the nature of their work, but also for the population in general, to get the flu vaccination. I think everybody in the listening audience is probably aware that there are a lot of tapings that are available, certainly a handful. CDC, in partnership with Johns Hopkins University, the North Carolina Department of Health, several entities have produced these or have them in production. And again, this is to a degree sort of a customized what your facility has and what works for your facility. And we are planning to do that with our Baptist colleagues to have one of those tapings produced in the near future that will be posted and announced via our usual channels on our website and so forth. And I want to close again by saying a thank you to the nurses in Alabama, nurses around the country, anyone in the listening audience, because they are such a critical player in health care. And in particular, when you have a challenge like Ebola and the preparedness activities, that becomes even more of a obvious thing, the role that they play on a day-to-day basis in the healthcare industry and service delivery systems. So I want to say again a special thank you to them. And finally, to again thank our partners in bringing this presentation to fruition, the Alabama Board of Nursing and the Alabama Hospital Association. So thank you.
Thank you.